Thank you, ladies and gentlemen, dear chairmen, and thanks to the organizers for inviting me again to this fantastic meeting. So, refining stroke risk estimation in patients with atrial fibrillation. I hope to try at least to keep you awake until lunch. These are my disclosures. In summary, I do not accept any personal fees from any company. So the background is that there are some knowledge gaps identified in the 2016 AF guidelines. And those include, for instance, the need for better prediction of risk for stroke and other AF-related complications. And we already know that several biomarkers have been associated both with incident AF, which I'm not going to be discussed, Renata did it great this morning, and also of outcomes in AF patients. And in the AF guidelines from 2016, it's clearly recommended that we use the Chance-VASc score, which is a score that we have had for several years now. It's well validated and used throughout the world. It's class 1A recommendation. But it also says that we should use bleeding risk scores, at least consider them, to identify modifiable factors for major bleeding, but also that we can use biomarkers for refined stroke and bleeding risk assessment. For instance, high sensitivity troponin and natriuretic peptides. In our group, we have worked a lot with multi-marker, multi-omics strategies like the discussion this morning, but we also tried to find a feasible way to use biomarkers in clinical practice and to develop affordable and available biomarker-based risk scores. So, for instance, we looked at the different variables in the Chance-VASc score and included some others as well in the Aristotle trial and looked at the relative importance of each of the variables for stroke risk. So prior stroke, as we all know, is a very strong risk factor for a new stroke. NT-proBNP and troponin I are by far more strong risk factors than any of the other clinical risk factors, including age. So congestive heart failure, peripheral artery disease, gender, diabetes, etc. are not strong risk factors when we enter biomarkers into this model. So based on this, we developed the scores based on 2 biomarkers, age, and a clinical history of stroke. We call them the ABC score, age, biomarkers, and clinical history scores. So the ABC stroke score was derived in the Aristotle cohort, a large clinical trial, which you all know a lot about. And we did our best to not optimize the score for this derivation cohort. We followed the guidelines, the tripod statement, and Harrell and other statisticians have developed guidelines for development of risk scores. It's easy to optimize a risk score for the derivation cohort. And that's an overfitted score that works very well in that particular cohort. So we did not the best score, but a rather good score, and easily available because we used troponin and NT-proBNP, which are available throughout the world. So C indexes were better compared to the Chance-VASc score, both in the full cohort, in patients with no prior stroke, that's primary prevention, and as a surrogate of no anticoagulation, we used those patients with a TTR less than 65%. We also validate that internally, but also externally. One in the stability cohort, which is a cohort of patients with coronary artery disease. 1,400 of those in this large clinical trial had atrial fibrillation, but very few had anticoagulants. So we looked at the ABC score compared to the Chance-VASc score, and as you can see in the no prior stroke group, the primary prevention group, the C index is 0.63 compared to 0.5. And in the external validation in the RELY study, 8,000 patients, a better performance by the ABC score, irrespective of subgrouping, etc. Another way is to look at calibration. Do we find in reality what we expect? So despite this score being a continuous score, we divided patients into those with less than 1% anticipated risk, 1 to 2% annual risk, or above 2%. And as you can see, both in the derivation cohort in Aristotle, in the validation and stability, and in RELY, we found the expected event rates at 1 year. It's less than 1%, it's 1 to 2%, and it's about 2% as expected. We also developed a bleeding risk score. If we refine risk score for strokes, we also need to take into account that patients have a quite delicate balance about bleeding if we enter them on anticoagulants. And then we introduced a rather novel biomarker, which is now commercially available throughout most countries in the world, I guess, at least in Europe. So GDF15, it's a marker of frailty, I might say. It's inflammation and oxidative stress. It's somewhat related to stroke risk. It's not a strong stroke marker, so we don't use it in the bleeding risk score. It's related to mortality and very much so to bleeding. So instead of NT-proBNP in the ABC bleeding risk score, we entered high sensitivity troponin, GDF15, and also very well-known biomarker called hemoglobin, easily available everywhere. So age biomarkers and clinical history of bleeding. Again, a derivation cohort in Aristotle, a validation cohort in RELY, because we thought it was more interesting to look at those patients already on oral anticoagulants when we look at the bleeding risk. Much better prediction, discrimination with the C-indexes around 0.68 up to 0.7 in the validation cohort. Once again, very good calibration. If we expect the bleeding risk to be less than 1%, it is so in both the derivation and validation cohort. If we expect it to be about 2%, it is about 2%. We compared it also to the HAS-BLED score, and as you can see, in those with HAS-BLED 0 to 1, HAS-BLED 2, or HAS-BLED 3, in those three categories, we can find high risk, intermediate risk, and low risk patients, irrespective of the HAS-BLED score. But of course, much more high-risk patients in those with HAS-BLED above 3, or 3 or above, sorry. Just recently, a month ago, the TIMI group in Boston validated the ABC risk scores in the ENGAGE AFNET trial. And they also showed very similar results with a good calibration. Here's both the stroke score and the bleeding score based on ABC. A large study with almost 9,000 patients. They also looked at categories of CHA2DS2-VASc and HAS-BLED. And most importantly, they found that in different HAS-BLED score categories, most often the bleeding risk is downgraded compared to the HAS-BLED score, which is reassuring if we want to give patients anticoagulants. So in summary, clinical risk scores in AF are limited by modest discrimination and calibration, and biomarkers are suggested for refined risk prediction already in the ESC guidelines 2016. ABC risk scores are repeatedly validated, also in observational cohorts, which I didn't have time to show, and they provide better risk prediction in AF patients on oral anticoagulants than risk scores based only on clinical variables. As you can see, there is a drawback. We have no validation of the risk score in patients without oral anticoagulants. And I say every time I discuss this, if you have a cohort of AF patients without anticoagulants and with plasma available, we are happy to collaborate. We give you the ABC score for free. But still, there is no prospective evaluation of any risk score on hard clinical outcomes, at least as far as I know. So we're now running the ABC-AF prospective randomized clinical study, performed as a register-based randomized clinical trial in the Swedish registry for AF called Auricula. So the hypothesis is that ABC risk score guided treatment improves stroke-free survival. So we're going to randomize 6,500 patients in approximately 40 sites in Sweden. We've just recently started this study. We have 65 patients as of today. So we give them ABC scored guided treatment or standard care. And we look at hard outcomes and, as discussed also this morning, also on health economics and health-related quality of life. It has support from several agencies in Sweden, but also from Roche Diagnostics. By that, I thank you for your attention.